We are live.
All right. So, hello everyone. I am Dr. Jasmine Marwaha, and I welcome you all to Global Interdisciplinary Summit. And now I'm back with another renowned speaker and a dental diva. And it's a huge honor for me to welcome her, Dr. Raquel Zita Gomes. And talking about her, she has received her PhD in implantology from the Faculty of Dental Medicine of the University of Oporto, where she also received her dental medical doctor and master's degree. Her thesis investigated experimental study of new biomembrane for guided bone regeneration. Dr. Gomes also completed postgraduate work in implantology at the Brenmark Institute in Gothenburg and maxillofacial surgery ward at Västerås Hospital, Sweden, and specialization course in implantology at the University of Oporto. Today, she'll be talking about how to deal with demanding cases of implant placement. And I'm sure that everyone will be going to learn something new. So before moving ahead, I would like you guys to register yourself for CE. To see speaker schedule and other details, kindly visit the link given below in the description box. Thank you. Over to you, ma'am.
Thank you. Thank you so much for your kind presentation. First of all, I would like to thank you, GOMA organization and Global Implantology Summit organization, namely to Dr. Kianosha and all the board members for inviting me to be here. It's really an honor to be beside such constellation of stars in implantology and in dentistry in general. So today my topic will be how to deal with demanding cases of implant placement. Sorry, my slides are not passing, just a minute. I'm just sorry, I have a technical problem, but let me try to figure out. Consigo passar os slides. Okay, so let's start. Sorry for this technical problem. So let's start again. Let's see if it works. Okay, so let's start. So where I'm from a beautiful country with beautiful landscapes, beautiful beaches and castles, and a very old and ancient culture. And if you don't know already what is my country, in the next slide you will know. So I think everyone knows the country of this football player, the best football player in the world, Cristiano Ronaldo. And I'm from a country that we like a lot football, and at the moment we are the European champions of football. So of course I'm from Portugal, but Portugal is a very small country, but very different from north to south. And I'm from a very small, not very small, but a small city in the north called Oporto. And Oporto is very beautiful. It was considered in the last years like the best travel destination in Europe for several times. And it's very cozy, it's very colorful. And of course, we also have one particular thing that everyone loves, that is the cellars of Oporto wine. So please join Oporto because it's a beautiful city to visit. So I started where I was from, and now I'm going to talk a little bit who I am. And who I am, I'm a very passionate dentist, oral surgeon that travels a lot to teach. My passion is a lot for teaching, and I've been traveling a lot for all around the world, and I spoke in more than 25 countries. And to be honest, I'm a woman oral surgeon in a man's world. So what is my journey? What was my journey till here? So I'm very passionate about what I do. And I worked for 18 years to get where I am today. And my journey started when I was inspired, mesmerized by Team Atlanta in 2001. I was a student at the last year of faculty, and I saw the Salma brothers in a conference in Porto. And I was so fascinated with their talk and their clinical cases that I swear to myself, okay, I will make a wish, and one time, one day, I want to share the stage with this top-notch idols for me. And that happened many years after. So around 16 years after, they invited me to be a speaker on New York University in the Dental XP Summit. And I was very honored to be the only one on stage. So my journey started there. I was still a student in 2001, and then I graduated in 2002. And to be honest, my dream was to uh, study in the United States, but unfortunately I couldn't afford it because it was too expensive. So in 2002, I went to Sweden to do a post-graduation. Between 2003 and 2006, I did my specialization in Portugal because I was working at the same time. Then I did my master's degree. And then a few years after having my child, I did my PhD in oral surgery. Then I was considered a specialist certified oral surgeon. And what is funny is that I wanted to enter to New York University or to UPenn, and in 2017 I was invited to be a lecturer at New York University, and 2018 to be a lecturer at UPenn. So I took the hard way to get there, but I made to the university in a different level, not as a student. So I always show this slide to people understand the kind of collaborations I have, and all the collaborations I have with universities, with platforms of education, with brands. They are always chosen because I know is the best for my patient. I always select the best products, the best apparatus, the best techniques. So these are some of my collaborations. You can read it on the slide. So where should we start this presentation? This will be between 45 and 1 hour presentation. I will try to make something a little bit easy for you to follow, but the best way to start is going back to the basics. So let's start with the basics. And we know that in nature and architecture, roots and foundations are the key to long-term survival. So do you think it's the same in implantology? Of course it is. So the same philosophy is applied to implants. So basically, if we have a good surgery that we consider the red, and we have a good integration of soft tissue, we consider the pink, we'll have then a good result of integration of the white, that is the teeth. The patient wants the teeth, but without a good surgery, without a good anchorage, we don't have a good result. So we need to consider all these steps. So let's talk a little bit about loading protocols, the difference between immediate, early, and delay loading, and the three most important things that you should consider to choose between each one of the types of loading. So basically, we should consider the ISQ, that stands for implant stability quotient, the torque, that is going to give you the insertion torque in the moment of the placement of the implant, and the bone density of the site that you are going to do the implant placement. So about loading protocols, by ITI consensus, we consider the immediate loading until 48 to 72 hours after placement. So it's not mandatory that we do the immediate loading in the hour or in the day that we do the surgery. It can be till 2 or 3 days after the placement. So this is important. Also, early, we consider between 48 hours and 12 weeks, and delayed after 3 or more months. So let's consider the torque. Everyone knows how to measure the torque. We have a motor that measures the torque. But what measures the torque? The torque measures the rotational stability, and only measure it once, because we can't reproduce this measure. Only if we are doing experimental studies and we do the counter torque. In that way, we can measure again the torque, but this in clinical we don't see. So what about the ISQ? The ISQ is completely different. It gives you the stability, but not the rotational stability. It gives you the axial stability, so the vibrational stability. And we can measure several times, not only in the implant placement, but also during the follow-ups. And even after a few years, 5, 10 years, if I do a follow-up and I unscrew my crown or my prosthesis, I can measure the ISQ. Also, normally we measure the ISQ on the implant, but also there are some brands like Breton that has tips that can measure the ISQ on the abutment level, not only in the implant level, but also in the abutment level. That is very good when we do a follow-up of long term. The objective is not to remove the intermediate abutments like the unicone abutments or the multi-unit abutments. So basically, what is ISQ? ISQ is basically a scale of stability. It can go from 1 to 100, and it uses resonance frequency analysis, so a vibration. And the acceptability of a healed implant will be between 55 and 85. Normally, when we have a very high stability in the beginning, the stability will go a little bit down and then have a plateau. If we have And then if we have a very quick drop of the stability, is a sign that we have some problem. So it's a warning sign. But how can I measure this? So basically, this is very easy to measure. We have what we call a smart peg. A smart peg is a tip that is specific for each brand of implants, or at least for each connection of implants, the type of connection. So we screw the smart peg between 8 to 10 newtons, and then we can use several apparatus to measure the resonance frequency analysis, so the ISQ. So there are several apparatus. The first one that was invented was Ostel, and then Ostel did some partnerships with other brands to develop other apparatus like the Mega ISQ or the Penguin. And now Ostel has a new apparatus that is very user-friendly.
Rencontré à Baden-Baden.
That is called the Beacon.
Les 100 meilleurs orateurs du monde. Et moi, je suis là dans une famille.
For someone that is talking at the same time as me to stop talking. I'm hearing someone in the background. Thank you. The normal behavior with ISQ with time is going down about 3 to 4 weeks after the implant placement and then starting to go up. So that's why, or we do immediate loading, or at least ideally we wait for 5 to 6 weeks to do the loading of the implant. In my faculty, we did some clinical research work with implants in the posterior maxilla. And why did you choose the posterior maxilla? Because it was the worst case scenario. And in the worst case scenario, that is the lower bone quality and normally quantity, we studied 2 groups. So the healed side, the post-extraction with some bone regeneration, and the sinus lift and filling prior to the implant placement. And we measured the stability during the healing time. And the materials and methods that we use some biomaterials from Osteobiol brand, namely MP3, that is a porcine xenograft, and collagen membrane that is from pericardium of horse. As you can see here, the results were quite surprising, because we were expecting to have a break of the ISQ during the healing time, and we didn't have. So how can we explain this? There's several ways to explain this, but namely, I think it has to be with the property of the microstructure of the implants used, and also about the biomaterials that we used. So if someone is interested in then reading the article, I can send by email. You can send the email for comments, or in Zoom or in Facebook, and I can send the article. So why should we measure the ISQ? To have guidelines. And so basically consider that we have a traffic light, and the traffic light means that the red light is a low stability, so we shouldn't do immediate loading. The yellow light should be medium stability between 60 and 70. So maybe we can do it, maybe we don't. So, and then the green light will be the high stability, and with these values, we can do the immediate loading. Of course, it's not the same if we do it in the single implant or in multiple implants, and I'm going to show the difference right away. So, as general guidelines for loading in each brand of implant, in all the brands of implants, of course, we have some adaptation, very small adaptation, but basically we have to consider the circumstance for single implants and for multiple implants. So for single implants, if we have torque lower than 30 and ISQ lower than 60, we should do a protocol of 2 surgical stages with cover screw. If we have torque more than 30 and less than 40, ISQ between 60 and 70, we are in the yellow zone and we should put the healing abutment, avoiding another second stage surgery. If we have torque more than 45 and ISQ more than 72, we have the ideal conditions to do immediate loading. So this is the protocol for single implants. And it's the same for multiple, not exactly the same. Why? Because when we have multiple implants, they are together. So we can have the thresholds of the values a little bit lower. So the difference will be that instead of 30, we consider the limit as 25. And then the second limit will be the 40 Newton centimeters. About the ISQ, the difference is in a single implant, we consider ideally ISQ more than 72. In multiple, we can consider more than 70 to have a protocol that will be predictable of immediate loading. So the other topic that we initially said, we talked about torque, we talked about the ISQ, and then we said about the bone density. This is what I call the old school classification of bone. And here you can have like the traditional classifications that we all learn in school in implantology from 1985, 1987, from Lincoln Zarb and from Misch. But these kind of classifications are good in theory, but normally you only know how to expect the type of bone when you do the surgery. So that's why nowadays we can have a different approach. We can consider this like the new school bone density approach classification. And we can do this in preoperative study of the TC or the CBCT, okay? And then we will have a radiological misclassification of bone density in Hounsfield's units. And in this case, we don't have D1 to D4, we have D1 to D5. And we have these kind of values to find the type of bone that we will have during the surgery, but before going to surgery, okay? So also in our faculty, my team, we did some research about this topic because we know that in the TC, we know that the Hounsfield's units are something that is very well studied. But nowadays, almost all the clinics have CBCTs and not TCs. So there were a problem that should we use the CBCT to see the Hounsfield's units? And we did a study that confirmed that we can have a correlation between the bone density, the ISQ, and the torque. Of course, we have some limitations, namely that the fact that the measure has to be done in the same apparatus, in the same area of the jaw, okay, and with the same calibration of the machine. But we found a very interesting correlation, a linear regression that made an equation that we could calculate the ISQ if we had the torque value, okay? But this was only value for 74% of the cases, and only in this type of implants, the knife thread implants, okay? So this was also published already in 2014. And if someone is interested, can send me an email and I will send the article. So let's start with a simple classification of insufficient ridges to you, the ones that are listening to me, understand my way of thinking and my way of decision when I have certain condition. So basically, we can have 4 conditions in the mouth. The socket, we can do immediate placement versus socket preservation. The low ridge, and we have several techniques to resolve the situation, namely the short implants, the tilted implants, the traditional GBR, the blocks, the 3 parts of the nerve, the inferior alveolar nerve, the lateralization and transposition of the nerve. Regarding the thin ridge, what are the techniques that normally we use? The most well-studied are the ridge split, the GBR with such a technique like Eastern Urban does, the thigh mesh or the mini implants. And what about the sinus? If we have a pneumatized sinus, we can have 2 options, or we graft or we avoid. If we graft, you can do it ocrestal or lateral approach. If we go sideways, we can do tilted implants or zygomatic implants. Of course, in some techniques of the zygomatic implants, you have to pass through the sinus. So we started going back to the basics, and now the show must go on. So let's start with the clinical cases. That's, I think, is the most important part for you to understand the concepts that I told before. So let's start with a case of an upper jaw that is a very atrophic jaw with a big pneumatization of both sinus and a very thin ridge that looks like a knife. And as you can see, these 2 molars that has endodontic treatment are lost. They have pathology and they will be extracted. But this patient had epilepsy and used the traditional removable prosthesis and had some difficulty in wearing the prosthesis and maintain it in the mouth. So I did a plan and I tell him, okay, we need a bilateral sinus lift and then we need some implants. But during the sinus lifts, I have to wait several months. So in this case, what did I do? So I did a different approach. I maintained the tooth temporary. I did the sinus, I waited, and then when I put the implants, I extract the tooth and do the implants. So it's a little bit outside the box approach, like Ziv Mazer normally says, but I do it a lot, this kind of situations when the patient needs the tooth as a temporization or as a way of sustaining the temporary prosthesis that is removable. And we're going to explain some techniques that we also use, like low-level laser therapy and the PRF, plasma-rich fibrin, in one complication that we have in one of the sinus. And the protocol here was to do 6 straight implants in the maxilla and then an hybrid fixed prosthesis. So this is the initial status, as you can see. The patient didn't have a good occlusion or even a good hygiene, but this is what we have. And here you are seeing that I'm drawing with a pencil that is sterilized, the sinus that I need to go to do the graft, but I'm trying to maintain those teeth, okay, temporary. This tooth, imagine when I will do the sinus, I will have a perforation of some cyst and some infection. In that situation, I will remove the teeth right away, but it wasn't the case, so I proceed with the sinus lift. As you can see here, we are doing a wall a little bit upper and contouring the roots of the tooth. And here you can see that we are raising the Schneiderian membrane to the palatal side. Here you can see a small video showing that we didn't have any perforation of the Schneiderian membrane. And normally I like to use this kind of technique that normally uses, sorry, I lost my, here. Someone is sharing my screen. Sorry, someone is sharing my screen. I don't know what is happening. Maybe someone from the organization.
Ma'am, I'm checking. Wait.
Someone called utilizer is using my screen. I don't know why. Okay, let's go back to again. So we are seeing that normally I use the technique that I maintain the lateral wall on the top, doing my new ceiling. But of course, in some cases, I also remove the lateral wall to then use it as someone to cover the window. Sorry, now my pointer is not working. Okay. Okay, now it's so after raising the membrane, I put some collagen membrane from Osteobiol to maintain just as a precaution to avoid perforating when I put the biomaterial. And I used xenograft. I'm sorry, someone is sharing a screen on my computer. I don't know what is happening. Salvador Jaef, I think, is starting to share the
Request, please.
I don't know what's
stop
happening.
sharing screen.
Someone is sharing the screen, but it's not me.
Salvador, it's a request. It's a request to everyone. Please stop sharing this screen. Dr. Salvador, please. It's a request. Yes, ma'am.
Can I try again?
Yes, ma'am. Perfect.
So please, I ask those that are looking at the webinar, please don't share the screen. Otherwise, I can't share my screen at the same time, okay? And I can't do the webinar. So then after, okay, let's go a little bit back. After putting some biomaterial inside the sinus, we do some compactation. This biomaterial has some collagen together with the granules that are porcine granules, xenograft, and then at the end, we do some putty biomaterial that is a little bit more thin and easy to block the biomaterial that is a xenograft inside the sinus. The composition is the same as the MP3, but is a little bit smooth, okay? And also from Osteobiol. And then in the outside of the wall, we are going to try to recreate a new wall, and we are using evolution membrane that is from pericardium of a horse. And we have an active part that goes inside and a non-active part that goes outside. I'm using Supramid 40 suture. And in this case, on the right side, we have after 7 days, we removed the suture, and we can have the final X-ray after the sinus lift. And here I did exactly the same on the other side, and everything went smoothly. And then after 6 months of waiting, I did an X-ray. The patient didn't have any complaints. Everything was supposed to be okay. And then my idea was, as I said before, to extract the molars that weren't supposed to stay and put the implant at the same time. But I had a bad surprise. So in the right side of the patient, everything was perfect, but on the left side, the sinus was not healed. So I didn't have any bone, I only have tissue. So you can see here, this was the situation after 6 months of healing of both sinus lifts. We knew already that in the anterior zone, we had a very thin ridge. And here you can see we extract the tooth, we cleaned everything, we opened. As you can see, is a very thin ridge. It looks like a knife. And after cleaning, we have this. And in the left side, we have this big problem. We had like tissue, inflammation, the bone marrow material got lost, and we have what we call the black hole. So we are seeing inside the sinus. In this case, we have to clean everything. We have to remove all the material that is not integrated, and we remove all the membrane that is soft. And then what did I use to try to proceed the surgery with less risks? I used the low-level laser therapy, LLLT. And I have two kinds of lasers, the red laser that is 660 and the infrared laser that is 780. The red laser acts basically as anti-inflammatory and antimicrobial when it's used with a dye. I'm going to explain next in the next slides. The infrared is 780 nanometers and is basically used for biostimulation of healing, namely when you have a paresthesia that is coming after a nerve transposition or lateralization. So I'm going to explain all this detailed a little bit in the front of the presentation. This is a small video showing the difference between using elbow, that is photodynamic therapy, and antibiotics. So now I'm going to explain what I did in this case. As we knew, we had some problems, so we used the dye, that is a blue dye from methyltoluene. And then we put the dye, we wait for 1 minute, and then we rinse with saline. And then after we rinse, we use the elbow blue, the 660 nanometers laser, soft laser, and is a diode laser, to decontaminate these places, because it will kill all the bacteria that is on the place. You can see here I'm using the elbow in both sides, including inside the sinus. And here then I'm starting to put my implants. In this case, I use Red and Blue Sky implants. And because I didn't have a lot of bone in the anterior zone, or I can do grafts and try to build the bone before I will put the implants, or I will do a different approach that we call the palatal approach. This was described by other authors, namely Patrick Palassi, Ziv Mazer, and others. And I'm using this technique for many years with very good results. So we go palatal instead of going the crest, because if I go in the crest with the first burr, I will destroy all the bone. So here we can see, or we are using the septus, or we are using the palatal approach. And if you see here, the values of the torque were not very high because of the circumstance of the bone was not in high quality or quantity, but the implants are quite long. And here you can see, after putting the implants, we are going to measure the ISQ, the implant stability quotient. And they can see here, the values are not very high, but not also very low considering the circumstance. Here, as you can see, all the implants are in place. And of course, in this condition, we should put a cover screw because the ISQ and the torque don't have good conditions to put a healing abutment or to do immediate loading. So we put the cover screw and we will close. But now we have to deal with all this bone atrophy, and I have to deal with the problem that I have on the left sinus of the patient. So what I'm going to do. So let's go see the problem that we have here. We have a membrane that is very, very thick because it had some inflammatory problem. And in this case, I thought that the best way to manage this was to try to suture the membrane to the wall of the sinus. Because the wall of the sinus was very thin, I could use the needle of my resorbable suture to do that. But if the wall was very, very thick, I can use a burr just to perforate and then to pass the needle. You can see here I'm using Vicryl Rapids 4 zeros, and I'm suturing the membrane that is already decontaminated by the laser elbow blue to the wall of the sinus. As you can see here, several stitches. Of course, it has to be with resorbable suture because it's going to be inside. And then I have to do some PRF, some plasma-rich fibrin. In this case, I'm using some membranes to stimulate the healing inside out. And I'm using some osteobiol evolution membrane, collagen membrane, cross-linked, also because it's more resistant than the PRF. Some more PRF and some bone graft biomaterial, in this case, xenograft, porcine origin for osteobiol MP3. And then we put some more plasma and then we close. Then I have to deal with the other problems that I have. I did the palatal approach, but now I need to feel a little bit the bone in the palatal side. And I'm using some xenograft, as you say, sometimes together with the liquid of PRF, the IPRF, and some membranes. This is the traditional GBR. And we are trying to protect these implants to long term. But even in these cases, many times we don't have any spira of the implants exposed in palatal. And because we have a very thick palate, because we have some connective tissue and some very thick gum, we have a very good protection to long-term survival of these implants with the palatal approach. We can do the same with the vestibular approach. This is Supramid 4 zeros after 15 days, after 1 month, after 6 months. And here in the day that I put the implants, of course, it didn't have stability to use nothing fixed. So the old prostheses were relined with a soft reliner. And then it went to home like this with the prosthesis and with the tooth that we maintain just to help to maintain the prosthesis. And you can see here the place that I did the graft on, the place that I had a failure graft before. And this then was done the final hybrid metalloacrylic screw retain rehabilitation. It was done by my team. And this is metalloacrylic, it's not ceramic. And this screw retain, and this kind of position in palatal is very good for the rehabilitation because many times you don't need to use any angled abutments because the implants are already in the right place of the single of the tooth. So in this case, it was my team doing the rehabilitation. And as I always tell, teamwork is always the best work. And I have a very good team in both of the clinics that I work more. Of course, the team is not only the doctors that have several specialties in orthodontics, pedodontics, endodontics, and also the assistants that are very, very important in helping us every day with our work. This is also a clinical case of bilateral sinus, a traditional one, not very complex. So if anyone wants to have this, I can send it also by email. So please leave your email in the comments or send me an email at the end and I will send it just to show that the technique, the steps are always the same. Of course, this case is more easy than the other one that I showed. And I started with a complex case on the upper jaw with a complication, with a very thin bone, with a different approach called palatal approach, okay? And now let's go to a clinical case that is difficult in the lower jaw. This case is very funny because it's a referral from a doctor from Italy named Dr. Pierluigi Casella, that is a prosthodontist. And he's in Italy, I'm in Portugal. And he asked me, because he had a patient that probably had indication of transposition of the inferior alveolar nerve. She already had lost the distal implant of the fourth quadrant, and the other implant was going to be lost. And I said, okay, I can do the surgery, no problem. Can you bring the patient here? So he brought the patient to Portugal. We did the surgery. I saw the patient during the surgery, and then 2 days after, and then he did the follow-up in Italy, and he did all the procedures of provisionals and final restoration. So I'm going to also show here some teamwork in different countries. So the patient, it was very careful with the hygiene, and it was non-smoker. And our idea was to do inferior alveolar nerve transposition because we didn't have enough height to put traditional implants, not even short implants. To have some considerations regarding this nerve, everyone knows that this is a sensitive nerve. So if we have some damage of this nerve, we will have some paresthesia or dysesthesia or hypesthesia, that is something sensorial, not motor. So when the patient is very concerned if he's going to not have function, it's not true, because this is only a sensitive nerve. Also, it has obliquous traject. So normally we only go to first molar, or in very specific situation to second molar, but not further back, because the nerve goes internally to lingual. And there is different techniques to mobilize the nerve with high success rate. I'm going to talk a little bit of the indication, like each technique, the short implants, the tilted implants, the GBR, the sausage technique, every technique has its own indication, and the lateralization and transposition also has a specific indication. Normally, it's the last resource where we can't solve this with the other situations that are simple. Normally, the indication is in the posterior mandible, because the bone is very corticalized, so it's very difficult to go very high amount of bone that we will reconstruct. And because normally we have the nerve passing very, very superficial. So the indication is having at least 8 millimeters of total posterior mandibular height. We are not talking about between the top and the nerve. We're talking about the top and the bottom of the mandible. Why? Because if we have less than 8, the risk of fracturing the mandible doing this procedure is very high. So at least 8 we should have of total height. Then, of course, we only do this procedure if we have a very severe atrophy of the mandible. In the literature, it's described less than 9. But to be honest, if I have 9, I will do short implants. I will not do a lateralization or transposition. So normally I only do this procedure when I have like 3 or 4 millimeters. And in this case, it's very difficult to use another technique. Some surgical and post-op considerations. This is the only mandatory surgery that we should do it with piezo surgery, because, for instance, in a sinus lift, I can do it with high speed, low speed, piezo. We can do it with several techniques, and if you are experienced, it's successful. In the mandible, it's not even thinkable of doing something that is not with piezo. Why? Because the piezo cuts the hard tissue but doesn't cut the soft tissue. So when we do a nerve lateralization, basically we only push the nerve, we put the implants and we push the nerve back. But normally we don't have the right conditions to do that, because if we push too much, we also have some paresthesia of the nerve. We can pull more than 5 millimeters. So that's why nowadays I do more transposition than pure nerve lateralization. And the transposition, what is the difference? We are going 3 millimeters in front to the incisive nerve, okay? Not in the mental nerve, not in the inferior alveolar nerve, in the incisive nerve, and we cut 3 millimeters in front, okay? the nerve that goes to the other incisive nerve on the other side. And then we mobilize the mental nerve, the mental foramen distally. I'm going to explain with a case so it's easier to see. Also, I have a very specific protocol to revert temporary paresthesia that always happens, but normally in 2 months it will recover totally. Of course, there are cases that takes more time, and there are cases that take less time. And my protocol is using corticotherapy to avoid the swelling and the compression of the nerve, PRF, plasma-rich fibrin, to help doing a new fascia of the nerve and stimulating the Schwann cells around the nerve and the stimulation of the conduction. The vitamin B complex 1, 6, and 12 that have a specific protocol of 6 pills a day, and the low-level laser therapy as a biostimulation. In this case, this low-level laser therapy is not the red one, it's the infrared one. You can see here the initial status, okay? The patient arrived to my office. And then we decided that that implant that was more than 20 years old and had some bone loss was not logical to maintain. So we did an explantation of this implant. Now we are localizing the nerve. We are using some pencil that is a sterilized pencil in the autoclave, a traditional pencil from school, but sterilized. And we mark the nerve to avoid even the assistants to be, you know, retracting in a place that they shouldn't be. So this is a way of me controlling where the nerve is without pulling, and the assistant also. And here we are doing the explantation of this old implant that is a Brandmark MK4. This old implant were not even with surface, were machined. As you can see, the position of this implant was not perfect, was a little bit vestibular. So we are going to try to correct this a little bit. And we are using also the red laser just at the contamination of the site of the explantation. But then at the end, we are going to use the infrared laser as a biostimulation for recovering of the paresthesia. You can see here, I'm trying to exhalate the nerve. You can see that we have a fascia around, and sometimes the fascia is a little bit strong, so we have to sometimes to release it a little bit. And I'm doing with my pencil the window, like it was a sinus lift, but in the lower jaw. Normally in the sinus, I prefer the round windows. Here I prefer the square ones. I'm using some retraction with some elastic. In this case, I use the elastic of the surgical gloves, because there are other ways of retracting the nerve without pulling too much, but they are more expensive and there's no need for that. So we use a traditional sterilized glove, and we cut the part, the upper part, and we use it to retract the nerve. As you can see here, the most difficult part of doing the window is around the nerve. When you go distally, normally it's easier. Of course, you have to work with a team that is experienced in doing this kind of procedures and know what they are doing. Here you can see that I'm already losing a little bit the incisive nerve, 3 millimeters in front of the mental nerve, so I can cut the incisive part. And here I'm doing the distal part of the window. And normally I only cut the cortical till I feel the medullary, and then I use some chisels, very, very soft, not even with a hammer, just by hand, to try to lose the wall, and normally it goes out. Here you can see that in this case, I did a variant that I use part of the bone that was around the nerve, the mental nerve, to try to block it distally. But sometimes it's not possible, so sometimes you remove that part and you leave only the nerve on the distal part. And you can see that we have medullary around the nerve, and we are going to remove this medullary, very gentle to not hurt the nerve. And we are trying to do like a slide of this little part of the bone to the back and to block it distally. And you can see here the place that the nerve was. We can see it very well. And here, even better, because we are already preparing the sites of the implants. Of course, this technique is logical to do the procedure and put the implants at the same time. It's not logical to do the procedure and then open again and do the implants. It has to be, it's logical to do everything at the same time. So in this phase, it's also very critical that someone that is retracting the nerve is gentle, but knows how to retract it to avoid me, that I'm doing the perforations for the implant placement, not touching with the burr in the nerve. As you can see here, we are putting like red and blue sky implants, long ones, because the objective is to do by cortical anchorage. We are using all the length of the mandible, and sometimes we go really to the basis of the mandible to have like the bicortical anchorage. And here we are putting the distal ones that were the easiest to put in the right position. In the anterior one that we did the transplantation, it was a little bit more difficult to correct the angulation. And the torque in all of them were quite high, about 50 Newton centimeter, and the ISQ was in all more than 82. So what do you think? Should I do immediate loading or not? To be honest, technically, I have the guidelines, the conditions to do so. But also, to be honest, I'm crazy, but not that crazy. So when you do these kind of procedures that are very delicate and very invasive, you should wait and go a little bit back. Instead of doing immediate loading, put the healing abutments and wait a few months. And ideally, in this situation, you should wait at least 6 months to have some bone regeneration in the wall, because it's a big wall to get to the nerve. So we need time to have the healing. So in this case, my decision was to put the healing abutments and not doing the immediate loading. You can see here the nerve. You can see there the place where we cut the incisive part. You can see the mental part going to the lip, and the inferior alveolar part going distally. Also here you can see the protocols that I used of PRF. I used not only the APRF that normally I use as a plug or as a membrane. APRF stands for Advanced Platelet-Rich Fibrin. And the IPRF, normally I use as an injection or together with biomaterial, can be biomaterial or autologous bone that you can use in a bone meal. And this is the called IPRF, injectable plasma-rich fiber. And you can see here I'm using my membranes of PRF, APRF, to involve the nerve, to have a new fascia, and to avoid the contact with the implants that are in place. And here also I'm mixing some APRF with the bone that I collected from the window that I used in the bone meal. And then I use some IPRF to mix it with it. So basically the autologous bone block on the lateral window is not logical to put all together in place, because most of the time it's not possible, because you already have the implants and it's not easy to fix it. And you should use some very complex screws. So the ideal situation is to use that autologous bone to do like a bone meal, and to do chips or small parts of bone, and use it as bone chips, and together with PRF. Here you can see the suture with supramid 4 zeros. And this is the protocol I use to revert the temporary paresthesia. As I told before, corticotherapy, PRF, vitamin B complex, and the level laser therapy. The laser can be done, the red and the infrared, with different objectives. So the red is with a particular protocol, and is 10 seconds per point, and basically is anti-inflammatory purpose. The infrared at 780 nanometers is much stronger, much penetrative, and is 1 minute and 30 per point. So it takes a little bit, some time to do all the trajectory of the nerve. The protocol should be between 6 to 10 sessions, and between the sessions should be 2 to 3 days, ideally. So I did the first session during the surgery, and I called the patient 2 days after because she was from foreign country, but she stayed 2 or 3 days in Portugal, and we did the mapping to see the paresthesia she had 2 days after, and she had only this small amount that we see in the picture. So in this case, the paresthesia was really small compared to the type of procedure that we done. And this is the X-ray immediately post-op. And then the doctor, Pierluigi Casella, the patient went to Italy, and he did some laser therapy there. And after 15 days, the patient was almost recovered, and after 1 month was totally recovered. So this is a very good case in terms of recovery. It was very fast. So the best way, as I said before, is the teamwork between, in this case, oral surgery, that I did the surgery, the dental assistants that are working with me, and they are very experienced, and the prosthodontics, in this case, from Italy. And then Dr. Pierluigi Casella, after a few months of healing, he put it some provisionals, and these provisionals were specifically splinted to avoid harmful impact on the implants, were made with bio-HPP abutments. Bio-HPP stands for Bionic High Performance Polymers. There's a special material that is commercialized by Bredend that has a property of shock absorber, and the acrylic crowns that also has some shock absorber property. And you can see here with the healing abutments, and then after some time with the provisionals, and then he decided together with me, we talked, and we decided the best way to improve the soft tissue was to do a free gingival graft and some vestibuloplasty. So he did this procedure, as you can see, and it improved a lot the keratinized tissue around the implants. And this is the final metallo ceramic bridge that was done by Pierluigi. And you can see here a very nice integration of the color and of the tissues around the bridge. Of course, here we have to use some pink ceramics to compensate the lack of high that we already didn't have before starting the surgery. And here, after 2 years, we did, he asked for a CBCT to see how it was going, the healing. And we even found the new foramina in the place that we left it. So a little bit more distally, and it's very, very easy to see it on the CBCT. So time goes fast, running fast. So let's try to jump into conclusions. And does anybody know what we are looking for? To be honest, when I go to a lecture, what I'm looking for at the end of the lecture is to have some simple take-home messages, something that I can use in my daily basis and that can help me in my clinical and my clinical part. So, as a general conclusion, sorry. Let's go back. As a general conclusion, we can say that nowadays with new technologies and techniques, we can do predictable and implantology in an efficient, faster and safer way. We talk here about several procedures, about PRF, about low-level laser therapy, about bio-HPP, about new designs of implants, and today with ISQ. So today, if we can have the good armamentarium to do the right procedures with the right indication, we can do really a good implantology and be safer in our way. Also, these are very important, some of them very basic, but very important message to take home. So as we know, torque measures the rotational stability and only measured it once. But the ISQ measures the axial stability and several times. We can even measure the follow-up after 10 or 20 years. Bone density can be measured objectively on the TC or in the CBCT in house fused units before going to surgery. So we can be prepared the kind of type of bone that we are going to find. The simple implant rules for immediate loading for single implants are torque ideally more than 45, ISQ more than 72. If you have these guidelines, you will do the right procedure, and if something fails, it's not going to be because of this, because you're using guidelines that are more than described in the literature in more than 1,000 articles. I'm not giving these rules only because of me. Of course, I have some research on this area, but also because of other literature that support this. When we think about multi-implants, as I showed in the ballerinas, when we are together, the forces are shared. So we can go a little bit lower in the values. The thresholds are a little bit lower. So instead of 45, we should have torque ideally more or equal to 40, and ISQ instead of 72, we can have 70 with no problem. And also that advanced implantology techniques have specific indications and high success rate. Of course, you have to understand first how they work and have training to do these techniques. Also, to summarize the role between antibiotics and antimicrobial photodynamic therapy, the elbow blue, we have one thing versus the other. So antibiotics is something that is systemic, so has some side effects. It can give resistance when you use it too much, and sometimes when you use too much the same antibiotics, it starts to have lack of effectiveness. The elbow blue, like the antimicrobial photodynamic therapy, is a local procedure. You don't have any side effects because it's done only in the implant or in the tooth or in the tongue or in the lip, because it's only not killing, it's killing not only bacteria but also virus. And there's no risk of resistance or lack of action because it is not systemic. Also, as a general conclusion, I can say that if you're never gonna try, and you're never gonna know, you will never gonna try. So you have to try a little bit harder, a little bit further every day, because otherwise you will stay in your comfort zone. You will do whatever you do every day, and okay, you can be a successful dentist, but you're not going to be a very good dentist. So please try to go a little bit further. Be aware of your limitations, of course, and have your training, but you can go a little bit further every day and get a little bit better every day. Because sometimes we have to be bold. We have to do something outside your limits, outside of comfort zone, because otherwise you can't go further and you can't reach the success. So no guts, no glory, no legend, no story. And just to finalize, I will have a few slides that I'm going to dedicate to women dentists, because nowadays we are a lot more dentists female than men. So we need to change a little bit the paradigm of having more women on stage, having more women in chief positions, having more women teaching in universities. So we know that evolution is coming, but women are more revolutionary. So I'm not a feminist, but I'm a realist. And for instance, in Portugal, nowadays, 80% of the students are women. So we need to really start to give more opportunities to women to have the same reality of men in dentistry. So in 2014, Dr. Delia Tuttle created a movement called Divas in Dentistry. This movement is a movement that tries to empower and to connect women dentists and try to give opportunities and give some visibility to the dentists. And we have several international leaders, and we have several branches in several countries. And here we did our first international event. This is a video of the second day of the event. It was 2 days and another day of reviews. We had 15 women speakers from 15 countries. also in this Global Implantology Interdisciplinary Summit together with GOMA. So it was supposed to have the second International Divas in Dentistry this year, but because of the situation of COVID-19, we have to postpone for next year. So next year, we hope that you can join us in Croatia between 7 and 8 of October, 2021. And we are not having only women on stage, but we also will have some men that support women a lot. And some of them are very well-known speakers internationally. You can see here the Major, for instance, that's already spoken in this event, and Rita and Komal that are already speaking in this event already spoke. So we have a lot of names that are internationally known, and we will try to do our best for next year. And finalizing, I will give here my contacts on LinkedIn. My name is Raquel Zita. On Instagram, Raquel Zita Gomes DMD. My email, this is my personal email. And I also share a lot of my work in a Facebook group that I created with the help of Delia Tuttle from Follow the Pink and Dr. Margaret Kashvere from Follow the White. That is called Follow the Red, that is dedicated to surgery. You can share it, your work, you can see the work of other people. I can sometimes share articles or cases or seminars. And the objective is to be a platform of sharing and caring for each other. It's for free. So if you are interested in surgery, please join. And thank you so much for this opportunity. And I really hope that you enjoyed the lecture. Thank you.
Thank you so much, ma'am. It was really a beautiful presentation and it was really a wonderful session. And it seems everybody present here is appreciating you.
Thank you.
So we have certain questions. First question is by Dr. Arun Garg. He asked, why do you put a collagen membrane inside the sinus if you had no perforation? Are you concerned it will delay healing and drive up product cost?
But because we are using xenograft, that is particulated xenograft, sometimes I use it just as a prevention, to be honest, just to have some collagen that will be coagulation, that will maintain my window that I turn it on the top on place, and it will avoid to perforate the membrane when I do the compactation of the biomaterial that is particulated. But it's only like an extra care, because in that case was not needed because I didn't have any perforation.
All right. And next question is also by Dr. Arun Garg. He asked, what is the reason you used an expensive horse membrane on the outside of the grafted site instead of the biological PRP membrane from the patient at much lower cost and with higher growth factors?
Normally, even if I use growth factors like PRF, APRF laterally, I normally also put collagen membrane. It's not Gore-Tex, it's collagen. It's totally resorbable. In this case, it's a cross-linked collagen membrane that will be disappearing for after 6 months, and it will give you less risk of not having a total wall done, because as you can see, the walls that I perform were quite big. To be honest, if I have a small wall, like for a single implant, sometimes I don't put the collagen membrane, I only put the PRF. But when I have big walls, like the ones that I showed, that were like with a different design and with a different and a little bit large, in that case, I prefer to put the collagen membrane, even if I put also the PRF.
Okay, all right. Then Dr. Vijay asked, are you planning ridge split in anterior maxilla or GBR?
If I prefer ridge split in GBR?
Yeah.
Yeah, it depends on the case because the ridge split has its own indication and the GBR has its own indications. The ridge split works well in thin crests, but we also have to have some little width, otherwise we can't split. Otherwise, if you split it, you will break. The bone regeneration, the traditional bone regeneration, when you are talking about, for instance, maxilla, normally it works well because it's a very well vascularized bone, it's a soft bone. But when we are talking about mandible, it's not so easy to do a traditional GBR with only xenograft. If you use autologous bone mixed or only autologous, yes, but only with traditional GBR is very difficult to have good results. And sometimes when you have the good results, then when you put in the implants, then that bone is not high quality, and then after a few time it will start to restore. Okay, if you go for mandible that are very atrophic and you only have cortical bone and you don't have indication of doing a ridge split, it's preferable to use autologous Curie technique, like going and take a plate and use osteosynthesis screws and collect some autologous bone from the plate and or from the ramos, and then even mixed with the xenograft. But the traditional GBR in the lower jaw, if the bone is very cortical, normally the success is not very high. But if you have some amount and some cortical and a little bit, at least 3 millimeters of width, the ridge split can be a good option.
All right. Then Dr. Tanaka, he asked, what do you think about relationship between insertion torque and ISQ?
In the literature, many articles refer a relation, but in other articles, there are no relation. So it means like sometimes you can have a torque, for instance, of 40 in 2 implants, and in one implant you have an ISQ of 60 and in another implant you have an ISQ of 80 in the same patient. So it doesn't measure the same thing. They are complementary. So technically you have to use the 2 measures together to take the decisions. The study I showed before, it was a specific type of implant and in a specific area of the jaw. And in this situation, it can be different. But sorry, I'm losing here the connection. Okay, are you hearing me?
Yes, ma'am, perfect.
Okay. So where I was, what was the question?
What do you think about relationship between insertion torque and ISQ?
Okay, normally they are not correlated, at least not in a linear regression correlation, okay? But in that study that I showed, they had almost good correlation in 74% of the cases. But if you change the type of implant that you are using, you can have completely different results. And we have in the literature completely different results with no significant correlation between one thing and the other. And another thing is, for instance, if you have an ISQ of 60 and an ISQ of 70, even with the same torque, the ISQ of 70, it's much better, but not in proportional to ISQ of 60. It's between having a cover screw, almost an abutment, and then having an intermediate load, and it's only 10 points. So it's not a proportional relation between the growth of ISQ and the growth of torque.
All right. Thank you, ma'am, for taking out the time to speak to us today on this very interesting topic. Your amazing personality and its inspiration to many women across countries.
Thank you.
And it was really a great session, very informative, and hosting your session was wonderful. So, ma'am, at the last, do you like to say some words?
I feel very honored. I feel happy to see a lot of questions and a lot of interest. I'm sorry with some technical problems during the webinar, but it's part of being online and not presential. But I think I feel happy with the result and seeing that people liked the webinar.
Okay, thank you, ma'am. So we'll be back with the next session tomorrow. For more information regarding certificate registration, speaker schedule, visit the links given below. Till then, stay tuned. Thank you.
Thank you. See you tomorrow.
Thank you, ma'am. Thank you so much.